Hello everyone and welcome back to the Research Works podcast. We are here starting our conference series at EACD in Galway, Ireland. And if you've been listening to our podcast these last few weeks, you would know that we have been really concentrating on the F words because the F words are the theme of this conference. And what a better way to talk about the F words and the co-founder of the F words, Dr. Peter Rosenbaum. Welcome to the podcast again.
Thank you. It's a pleasure to be with you again.
It's lovely to have you here because the last time we spoke was a few seasons ago. And you left us with a lot of things to talk about. Myself and Ash have been talking about it for quite some time. And the last thing you said to look into was My Left Foot, an autobiography by Christy Brown, written in 1954. And you've written a paper about it. And he's from Ireland. We're in Ireland. We're talking about the F words. So I feel like there must be some thoughts here for you, Peter.
There are indeed. Christy Brown was a hero in many ways. He was way ahead of his time, as was his mother and many of his siblings, in recognizing what amazing talents he had as a thinker, as a writer, as an artist, despite having significant functional challenges with his cerebral palsy. And having read the book several times, having seen the film several times, and the very good film, which I recommend, it was apparent that the ideas that we're talking about in 2026 were all there in front of our noses in 1954, but we didn't see them. And quite frankly, a big theme about the whole of the F words thrust is that the ideas we're talking about are not strange ideas. They are simply emphases on things that have always been there that we haven't seen. So in Christy Brown's case, his family was incredibly important to him. His mother recognized his ability despite his functional challenges. His siblings were very, very good to him, and there's some very funny scenes that he describes and that are shown in the film as well, with a lot of mischief and a lot of fun. He was clearly a very thoughtful man who had the ability, in his own way, with his left foot, literally, to express himself, and became a very highly regarded author, not a crippled author, a very highly regarded author. And it just speaks to the fact that there's so much that we have failed to pay attention to, that I thought it was important to say, not that we've invented anything, but these ideas have been there forever, folks, and let's start paying attention to them. And this is so beautifully illustrated by his life and his story.
It really, really was. And I was shocked, I have to say. I had never heard of it before until you introduced it. And you can't help but to go through the role of his mother. Find inventive ways and almost really advocating for him as well, that it didn't have to be done the right way. It was done his way. And that is just so important, isn't it?
And there were a few people in his life who were tremendously important to him. Certainly his mother and his siblings. Also, by absolute good luck, the pediatrician who offered support to him was also an author and recognized in Christy's writing the quality of what he was saying and helped him to get started. And, you know, so much of life is chance. And here was a chance encounter with somebody who saw who he was and nurtured his talents at a time when many people would have thought the doctor was a fruitcake for bothering.
It's quite incredible. And now shifting to where we are now, how would you contrast that? If Christy Brown were to be here in 2026, what would you say would be the difference in terms of how far we have come along, where we have moved to, and the role of the F words?
I would hope that people would recognize his ability. I think there's still a long way to go because our intellectual inheritance in our field of childhood onset disability is still strongly biomedical. It's shifting a lot. And I think it's important for people who haven't heard of the F words to know that they are nothing more than a smart-ass attempt to bring to life the World Health Organization's framework for health.
Absolutely.
And the framework is an integrated framework that reminds us that there are biological elements to any health issue.
Yeah.
There are social issues and dimensions to any health issue, and there are personal dimensions to any health issue. And our tradition has been to focus on the biomedical, to figure out what the diagnosis is, to find the right treatment, to be terribly disappointed because we can't treat and fix cerebral palsy the way we can fix a broken limb.
Yeah.
And yet, if we think more broadly and we recognize the capacity of parents to observe their children and the importance of us listening to parents.
Yes.
And it took me a long time to credit parents with the things they were saying. And if we think most particularly about the question that needs to be answered, what is the impact of this or that or another chronic health condition on a child's development?
Yes. Yeah.
And we know we work in the field of developmental disability and then immediately forget the first word.
Yeah.
And it is children's development that's important.
Yeah.
I have the privilege at the moment of watching our son's 1-year-old developing, and it is sensational once again.
Yeah.
And you see that we take for granted a child who's cruising along the furniture.
Yeah.
And we don't worry that they're holding on to the furniture.
That's right.
Because we know that at some point development will continue and they will let go. But when a child with a disability does that, we get all upset and say, oh no, you have to let go and walk without holding on. And that just...
How did that come about?
Forces it. We're trying to force people to think about the developmental aspect of any skill acquisition. We start off doing it crudely, but it's cute in a baby. And then with time and interest, we do it a little more and a lot more and get better at it. Yes. And that's true for children with disabilities as well.
Yes. Can I ask on that, which is you touched on it before. There is this tension, isn't there, in terms of how we're taught, how we learn to assess. It's very deficit-based. It's not enough of this, impaired this. And the remedy for that is we need to do these things to address it. But then on the flip side, when we have a strengths-based approach, it really flips it on its head because we actually are trying to work with what the child does have and how we can empower them. How do we wrestle with this tension in terms of how we're taught and wanting to identify what someone doesn't have that might lead to a diagnosis versus where we can take it?
What I probably sound like a broken record to people who've heard me say this many times. We don't teach child development. We don't teach people who work with children that children are fundamentally beings in the process of evolving, of being, becoming, belonging. And if we were to teach that, and if we were to ask people to think always, what is the developmental implication of this? What is the child doing right now? What does it tell us about their interests and their abilities and whether they do it this way or that way or another way? I also like to remind people that we have traditionally had very strong views about what was normal and abnormal.
Yes.
And there was a time, hopefully in the past, when being left-handed was a bad thing, and you were forced as a naturally left-handed person to change and use your right hand.
Yes.
And in 2026, I hope that sounds ridiculous to people.
One would hope so.
But it's an illustration of the orthodoxy that interferes with our being sensible.
Yeah, sure.
If we pay attention to what's interesting to children and nurture that, they will work at it.
Yeah.
They don't have to become obsessed with that activity, but at the time they're interested in it, if we set the world up for them so that they can do the things they want to do, then they will do them and feel competent.
That's
if they feel competent about this, maybe they'll feel competent about that.
And it relates to everything that we do as humans when we're trying to learn something, isn't it? It makes sense. Something that I do see a lot of is there's a lot of debate around this, crawling, the value and importance of crawling. And I've seen fiery debates online saying crawling is not necessary for mobility, where others are like, you must crawl. In fact, there was a survey being done where therapists would say, look, even if they're walking but they haven't crawled, we'd go back to crawling because of the integration of reflexes. And there are hot debates with that online. How would you...
That's horse feathers. It's absolutely nonsense. And it goes back to a particular approach, a seriously discredited approach to intervention for children with disabilities called patterning, where you had to go back and learn to do again, or for the first time, the usual ways that things happen.
That's right.
My one-year-old grandson has just begun to crawl. For a while, he was commando crawling.
Right.
He also was moving around relentlessly. And the issue isn't crawling, as in hands and knees reciprocal action. The issue is exploring, using mobility for the purpose. Mobility has its own intrinsic excitement and value, but to a large extent, it is allowing children to get into what adults call mischief. And how they do it doesn't matter.
That's right.
And there is, to my knowledge, absolutely no evidence, zero evidence that children have to crawl. And as one anecdote is, when I first went to McMaster, I wanted to make videotapes of typically developing children. And one of my close colleagues was a speech therapist whose first child was about 9 or 10 months old, and she kindly agreed to allow us to videotape her daughter. Her daughter never crawled.
Right.
Her daughter, her typically developing child. And so here was my first illustration. And it wasn't chosen. It was just by chance. The orthodoxies of how things have to be done are just ridiculous.
And it has been so long-standing. It's almost until you stop to think where it came from. But it feels like it's been passed down from one to the next. And there is a requirement for us as clinicians to challenge ourselves.
Yes.
It's uncomfortable, but necessary from a learning perspective. How would you advise clinicians who have been practicing in the field, say, like I hear this a lot, I've been in the field now for 20, 30 years, this is how I do things. I find that...
And I know it works.
That's the one. How can we as a profession continue to challenge ourselves and that being part of what we should be doing rather than a critique, I
We
suppose.
live in a world that claims to be evidence-based. So let's ask people to show us the evidence that what they're proposing is right. My favorite example of all of them, if you really want to irritate people, talk about W-sitting.
Brilliant topic, yes.
W-sitting is one of those things that gets a lot of people's blood pressure high. And I have looked into the literature and can find zero evidence that W-sitting is a problem. Now, children with cerebral palsy often W-sit, but the W-sitting didn't cause the cerebral palsy.
That's right.
The cerebral palsy, if you will, caused the W-sitting because of internal rotation of the hips. But it's also typical, it's also seen in a lot of typically developing children. And even if a child has cerebral palsy, W-sitting is a way of being secure, having your hands free for play, having your back straight, and so on. Side-sitting is, and we all know this because we've all been to picnics, where we side-sit briefly and then move out of it into another position.
That's right,
And one story I love to tell is seeing a child in clinic for the first time, about a 2 or 3-year-old with cerebral palsy, and I said to her mother, does she W-sit? Yes. Do you try to stop her? Yes. Does it work? She said, no. I said, let her W-sit.
That's right.
The mother got up and came over and gave me a hug. Because she had been beaten up time and again. Let's find things that are important. And W-sitting is not going to hurt children. And it is adaptive, which is why they're doing it.
That's right. It's funny that you bring up W-sitting because it is very topical. I was recently teaching some of my new graduate therapists, and I said to them, W-sitting is perfectly fine, gives them a position of stability. And even as I was describing all of that, there was this little part of me that felt really almost naughty, because for years my profession has been saying, do not W-sit. It is terrible for them. So even as I was talking to them, I go, look, that's completely fine. We're not going to shame parents, shame children for W sitting, because now they can play, their hands free. And who taught me that was a mother who taught me that. And who was I to then say, your day can be a whole lot more complicated. How about you just get out of W sitting? It doesn't feel right. The value of the F words really humanizes a child and their family.
And their family.
That's right.
So good for you for listening to the mother.
It was the most influential thing I've ever done.
The grace and respect to listen to her.
And it is more and more what we need to be doing. There's terms for it now, you know, there's co-design, people have lived experience and been involved in research, but that's research. In actual clinical practice, every single day, that should be a given, shouldn't it?
A parent with whom I work very closely said to me a few years ago when we started working together, you have textbooks, we have storybooks.
Yeah.
7 brilliant words in a very compressed sentence that really make a serious point about the fact that we've seen lots of it.
Yes.
She's seen lots of him.
Yes, that's right. That's right.
And the challenge we have, if we're going to talk about personalized medicine, and you'll hear me say more about that in another talk, is that we have to pay attention to this particular child with their abilities and interests and challenges, this particular family with what's important to them, and blend our expertise and experience with their reality.
Yeah, that's right. That's right.
We cannot have a one-size-fits-all or a one-approach-fits-all for children with conditions like cerebral palsy.
Yeah. As therapists are looking into interventions or opportunities for children to be more physically active, one of the things that I do notice a lot of, and there is still a divide for this, is the value of participation and being out with your friends and your family. We talk about that a lot. But then there's also this other side where there's this real hard set goals that might be set on improving head control, reducing spasticity. I saw a post the other day that said if you position a child in a certain way, the spasticity melts away. There's really strong language that I think lures people, even clinicians and families, into this belief that if you do certain things, these impairments in body structure and function will be addressed, and therefore the rest of life will look better.
And it's the therefore that is the problem. There is an assumption that it is issues like spasticity that interfere with functioning. But spasticity is a manifestation of impairment at the level of the neuromotor system. And there's some very nice work done by one of my good friends and colleagues, Virginia Wright, who looked at changes in impairment, changes in functioning, and changes in body structure and function. And she looking at using the spasticity clinic and Botox intervention, and showed very definitely that using botulinum toxin did in fact decrease spasticity as measured by the Ashworth scale, did lead to improvements in range of motion of the major limbs, did not change activity, did not change participation. So yes, we can change aspects of the body, but unless they're making a difference to what people want to do, we have to ask why we're doing it. Now, if the spasticity is producing pain, then of course we should address it. And I want to be clear, because I sound like a therapeutic nihilist. I'm not. But I think we have to say, what's the question for which this intervention is the answer?
That's right.
And if the question is how do we enhance functioning, then we have to be very clear that spasticity in this example is interfering with functioning. And of course, at times, spasticity supports functioning.
That's right. Yes, yes.
So we've got to get past the idea that if we can only change the body structure and function, everything else will follow. It's not necessarily the case.
And it's really interesting as well, isn't it? Those are thoughts that have been really held and beliefs that we've had for many years now. This leads me to an article, and we spoke to the lead author, Olivia Dahl, actually, on a paper that was titled Tragedy of Promising Happiness Through Overcoming Disability. And there's a quotation that opens the paper, which I thought was very, very confronting, very good for us to read. And the quotation is, "The idea is that disability has to be a journey and something to be overcome."
Yep.
I'm quite tired of that, because I don't see cerebral palsy as something to be overcome, but rather as a condition in life that just exists and colors the way we both encounter and are encountered by the world. She spoke to many adults with cerebral palsy and really opened up to her, because she herself has cerebral palsy and was able to really share her experience too. So it's a different kind of qualitative interview. What are your thoughts on that? Because I feel like the title in itself is so compelling, the tragedy of promising happiness through overcoming disability. There's so much we can learn from our adults, aren't they?
Nobody would choose to have a complicated life. Nobody would choose to have impairments that interfere with what they want to do or the ease with which they do it. But the idea that there is some ideal to which people must ascribe and is really arrogant and quite foolish. And it speaks to very strongly to an ableist view of the world.
It does.
She is talking to, or listening to, I should say, adults who have grown up in a world that expected them to overcome their disability.
Yeah.
What those young people probably have also done, which hasn't been recognized, is solve problems. I've been doing some reading about writings of adults with impairments who talk about how they are good problem solvers.
Yeah.
And we don't give them credit for that. We don't give them credit for figuring out how else things can be done.
That is so good. Yeah.
Rather than having to do it nicely. And again, let's go back to the left-handed example.
Yeah.
Must be terrible to be left-handed. But then there was a time when it was terrible to be a girl.
Yeah.
Because boys were prized.
That's right.
And again,
That's right.
let's just recognize how strongly acculturated so many of these ideas are. Father, in the 18th and 19th century, it was the males who were going to inherit the property, not the girls, not the females. And so families needed to have boys.
Yeah, yeah.
And it was tough to be a girl.
Yeah.
That's not a frivolous comment. It's a silly comment in 2026.
It does sound
But
rather.
it's an example of the tyranny of a particular way of looking at the world when the world has much more to offer if we're more flexible in how we think about it.
That's right. And it is about our thinking. It is it's completely about our approach, how we work with families and the education, and actually taking the time to listen to what it is that they want and what solutions they have already found, because they may have already found some solutions.
I commented earlier about living and working in a time of evidence. And we have some very strong evidence from our Envisage program, an Australian, Canadian co-production.
Beautiful.
Where parents were introduced to the ideas along the lines of what we're talking about today. And there was very significant enhancement in their sense of competence and their sense of confidence as parents and their sense of empowerment, because they were being encouraged to do things that made sense to them.
Yes.
Not specifically W sitting, but W sitting would be an example of that.
Yeah.
And helping them to see that many of the tyrannies that are classically part of our field are just that. They are not evidence-based.
That's right.
And what I'm talking about now will probably irritate some of the people who listen to it. And that's fine. I'm happy to have conversations with them. I'm not trying to tell them that I'm right and they're wrong, but I am trying to say that if we open our minds to thinking about what's important to families, to thinking about and empowering what's important to children, then we will see things just as Christy Brown's mother did. There was some beautiful work, as far as I know, the first studies of the provision of power mobility to young children with significant motor impairments. And this was work done by a friend named Charlene Butler, whose PhD thesis as a special education teacher involved providing 6 children with significant functional limitations.
Yes.
Cerebral palsy, or spina bifida, or arthrogryposis, or spinal muscular atrophy. The diagnosis didn't matter. What these young children all had in common was profound limitation in mobility.
Yeah.
And she provided them, she worked with a rehab engineer, and they provided them with small powered mobility. And she did single subject studies on all,
Beautiful.
and the results were astonishing.
Yeah.
The children were empowered both metaphorically and literally to start exploring their environment.
It's so significant, isn't it?
And enhance their development.
Yeah.
I mean, and that was 40 years ago.
Wow.
And we're still discovering this and being amazed by it.
Yeah.
These things, the point of all of this is these ideas have been under our noses.
That's right.
But we haven't seen them because we weren't ready to see them.
Yeah, that's a good point. Let's set that as the standard now, I feel. There is enough there. Peter, what would you say as a final remark to the people who are listening, clinicians who want to integrate more of the F words into their practice? What would your advice be for them?
I would say, first of all, recognize that the F words are a way of animating the World Health Organization's framework for health. And that framework was published in 2001. It was an adaptation of a framework published 20 years before that. The difference between the 1980 and the 2001 versions is that the 2001 version had the input of people with disabilities.
Yeah.
It provides, instead of a linear framework of disease causing impairment, causing disability, causing handicap, it now has an integrated framework where the hip bone is connected to the thigh bone.
Yes.
And where we intervene doesn't necessarily have to be at the level of body structure and function. It may be, but it may equally be at the level of the environment.
Beautiful.
It may be at the level of empowering parents. It may be at all of these places. And so we are now thinking much more in the jargon of the biological, the psychological, and the social all together.
Yeah.
And in other words, we have widened our purview beyond the best of our therapies, which we should always use.
Yes.
But when we're doing our therapies, we should always say, what's the question we're trying to answer? What's the evidence that this therapy in this child with this issue makes a difference?
Yes.
And the distinction I would make between does the therapy work and what I'm talking about now is does this therapy make a difference to this child's predicament? When I was a medical student about 100 years ago, we had a patient who was very ill with pneumonia. And he was getting intravenous penicillin. Penicillin is an antibiotic that predates you by many decades, but it was a very, very good antibiotic.
Yeah.
And he wasn't getting better. And the reason he wasn't getting better is because he was getting an excellent drug for the wrong treatment, for the wrong disease. He had tuberculosis.
I get that. Wow.
And here's an evidence-based intervention, penicillin, but not evidence-based for that disease.
That's perfect. It's a great analogy.
So we have responsibility to be always thinking about whether what we're doing is the right intervention for the right problem.
Yeah.
With evidence that it will work.
Yeah. Peter, as always, every time I speak with you, you bring truth, you bring thought to what it is that we do, because we love our profession. And we want it to mean something, and we want it to actually help someone live their best life. So thank you so much for speaking with us. Thank you for sharing the F words with the world and creating this common language that actually just sees people for people and not to over-medicalize in any scenario, because we all just want our children to live their very best lives.
Can I add one comment?
Of course.
About the F words, and that is that the F words are being used all over the world in at least 35 languages that we know of, and probably more than that. And parents love them.
They do.
Because they speak to their particular predicament and opportunities to help their children function and develop.
Something so wonderful and to be proud of, and to see how that's evolved. And here we are, whole conference based on the F words. I mean, that's just amazing. That is absolutely amazing.
I agree.
Oh,
Thank
well,
you.
the public lecture's coming up. It's pretty exciting. To everyone listening, that was incredible. Get on it and take on the challenge that Peter's put out for us, because it's worth doing. And I think the children that we work with who grow up to become adults, this is something that we want to make sure we get onto. So many more episodes to come. We'll talk to you all again really soon. Bye for now.